we live in one of the states where RK is very popular, and because we have a large retirement community, also very prevalent. But there's not a week that goes by when I don't see RK. RK causes a multitude of problems. I like placido discs for illustrating some of them. And here, this is how the should look. And here, obviously, there's a lot of distortion. In the right eye, same thing in the left eye. And this patient had RK and AK, astigmatic keratotomy and radial keratotomy.
Would that normally be done at the same time or at different periods of time? And why would an AK later be added on a patient with RK?
Usually done at the same time. I've also seen patients where the astigmatism was changed, where at some point you just end up with AKs all around. The challenge with AK and RK is that the incisions don't always stay closed. So the challenge here, as you can see, is that inferiorly, more likely than superiorly, incisions can gape or open. And what will happen is that, one, you get more distortion. So let's say usually the AK incisions are placed in the steep axis of the astigmatism. In this patient, when we look, you'll see that this is now the flat axis because it overcorrected. And the overcorrection, you can see here, one, you see lots of epithelial compensation. It gets very thick in the center and very thin over the periphery, over the elbow. So RK goes from this. If you push down, it goes like that. So it's almost a rectangle. And so it makes the epithelium very thin over here. If you add AK, now you have a rectangle and it bends even more, so it gets even flatter. And this sticks up, so you get thinning of epithelium. People can get recurrent corneal erosions over these, lots of pain, and obviously vision is affected.
I was interested also because you mentioned the inferior are more likely to gape open than the superior. Is that more of a dynamics of the lid movement or something else with the cornea causing that?
Pure guess, I think it's the lid because the lid rests on top, so it pushes in. And obviously if there's pressure on a round body, since fluid can't be compressed, it has to give out somewhere else. So it's like in on the top, out on the bottom.
Well, this is the actual display we get from the pentacam where we can see the axial curvature, elevation on the front and the back as well, and the corneal thickness as well. But that, to me, already off the bat looks quite abnormal in that topography.
So I mentioned the benefit of placido disc. Placido disc has less problems with a very highly abnormal cornea than pentacam. Pentacam at some point just throws its arms up and like, this is just weird. I don't know what I'm looking at here.
We can actually look also at the epithelial thickness map.
So as mentioned before, and this is characteristic of RK, very thick, and any myopic LASIK would also have thick central epithelium and thin periphery. In RK, it's very thin in the periphery. So in this, from the Cirrus OCT, you usually get a range of the epithelial thickness. And as you see, the max in the center is 70. And then the thinnest point, which tends to be in the 5 to 7 millimeters, so these are 0 to 2, 2 to 5, and then 5 to 7. So right around here is the thinnest point, is 31. So it's almost a 40 microns difference between the two. And below 30 is where the epithelium starts to break down and get unstable. So a thickness less than 30 is not stable epithelium, which means erosions. And oftentimes when you look at it staining-wise, it looks like that pattern that you see in a keratoconus over the cone. You see kind of almost lines or dots. And people call this, they say, I don't know what they call it, but dryness, which it isn't, it's unstable epithelium.
Just to repeat what you said, because I think it's so important also, the fact that you are expecting with a myopic RK that we have a thicker epithelium in the center, and to me that almost feels like a compensation where it's just trying to build up that tissue and smooth it out as much as it can to match the raised up peripheral RK scar tissue. I think that's fascinating.
And almost try to match the curvature. One of the theories why people get central scarring after RK, even though there's no RK scars, is this. So the eye tries to compensate, tries to build up the center, and the buildup can also happen in scar or again initially with just epithelium.
And you use the word scar, and is it more of a true scar, like a stromal scar we would expect, or a subepithelial fibrosis, or maybe a combination of both?
Subepithelial fibrosis, so it's anterior to Bowman's.
Okay, interesting. This is just side by side looking at the image of the irregularity of the cornea side by side with its topography.
Again, in this axis is the AK that's gaping inferiorly, and then also in this axis, the pentacam will usually show central flattening and then a very sudden steepening as the table, if you will, drops off from flat to very steep.
Now, this video is a very short 2-minute video, but I think there's a lot to learn from this video. First step is I noticed that through those wounds, you're actually, it looks like you're opening them up more.
Opening them up, removing the epithelium so that way I can close them better. I place sutures. This was a very small AK superiorly, so it's just one suture that goes here. All the knots I trim and rotate into tissue to make sure they don't irritate. On the bottom, because it's a little bit wider, I place two. Unfortunately, which makes things more difficult, there was an RK cut that almost went through the AK.
Now, as far as these stitches being placed, are these going to stay in forever? How long? Is there another way to more permanently change this? Or you just assume the stitches are in and they're going to be in forever and fix the corneal shape?
Well, they'd stay in as long as they don't cause any problems, but ideally at least for 3 months. After 3 months, you get some scarring and some subepithelial fibrosis, so the suture tracks will hold things in place. But if they don't cause problems and actually patient sees better, I like to leave them in as long as possible.
Well, I think it's an amazing, here's the one-day post-op appearance of what those stitches look like in the cornea, 1 superior and 2 inferior, to try to close up those gaping wounds.
And again, here, this is, so the straight is in front, and this little knot is behind, so it's further in, deeper into the cornea, and I try to make sure that these ends, at least, are pointing in one direction, which would make removal a bit easier. So to go, if I were to remove this, I would cut it here and then pull in this direction. That way the suture rotates out in the area of least resistance.
Is it also a way to make the actual knot pass through the least amount of tissue as well, if it's coming out that direction?
Correct. So I try to place it on one side of the wound. As you can see, I rotate it in, and then taking it out, I try to limit the amount of tissue it has to travel through, less likely to break.